Okay, students, welcome back. Here we are in the course of bioethics within the master's program of molecular and cell biology at St. Thomas University. We're shifting gears now into end-of-life issues, having covered a number of beginning-of-life issues. So the topics continue to be controversial and exciting, but it really takes it's like a surgery. You have to be able to cut through tissue and cells very delicately and make the appropriate distinctions, which we'll continue to make today, right? So if there's nothing from previous lectures, I'm going to move forward then. I like to begin with the evidence, in other words, with the biology of the thing, with the biological setting or the clinical setting, because these are facts that don't require belief, all right? Belief is at a different realm. Belief is in the area of faith, spirituality, and religion. But here, when we're talking about biological evidence, then it's true whether we believe it or not. And these are universal facts, meaning that they occur to life on Earth as we know it from the organic perspective. And I'm saying this because first I'm going to focus on vital organs. And then after that, we're going to shift to the bioethical analysis, which is making distinction between ordinary or extraordinary means of life support. All right, so those are the two main topics of today. First, a quick review of vital organs, human vital organs, and then ordinary and extraordinary means of life support and the bioethical distinction between those two. So, a previous review, if you will, to the organs themselves is just to put it in context, what is known as the levels of biological organization or the hierarchy of life, right? Well, the very first thing, even more basic than that, is what is the unit of life, the basic unit of life, the cell. And so that's what we call living. Organelles in themselves have a function in the cell, but if we lay out a bunch of organelles here, all the organelles of a cell, that's not going to be a living thing. They have to work in synchrony to allow for organic life as we know it. And even the cell will apply to protozoans, right? What's an example of a protozoan? Protozoans, rather, I meant prokaryotes. So prokaryotes and eukaryotes, I'm going very basic here. An example of prokaryotes, the big domain of bacteria and archaea. And because they don't have an organized what? Makes them prokaryotes, organized nucleus, right? But eukaryotes have a true organized nucleus within a nuclear membrane, which is a double membrane, by the way, very significant about that. So even in eukaryotes, we have some unicellular organisms, right? Where the whole cell, where the whole organism is a single cell. What are some examples of those? Yeast can be one, and even yeast colonizes, right? They form colonies. So each individual yeast bud is a cell, is an individual, but even they live in colonies, and there is an interaction as they work on saprophyte, a substance. But I was thinking of protozoans. Remember the amoeba, paramecium, euglena, all those guys, right? Single cell organisms that have a true nucleus and live as a single cell. The waters of the earth are full of it. Even more prevalent on the oceans, the upper couple of feet of water, what is known as plankton, which can be subdivided into zooplankton and phytoplankton, whether they photosynthesize or not. Okay, it's just general review. So yes, the cell, but then when we jump into macroscopic plants and animals and fungi, then we're talking about multicellular organisms. And so there's going to be some kind of interaction within these cells, and that's what's going to form this hierarchy or these levels of organization, right? So that cells that have a similar function we call tissues, right? Okay, and tissues with a similar function, organs. Organs with similar functions will form entire systems, okay? And notice here, and these systems, we call them organ systems. So you see that in textbooks, but a system involves a number of organs, any number of organs. It can be from 2 or 3 to a full dozen organs, all right? So in this case, in the case of organs by themselves, like a brain, a liver, a heart, etc., that's the noun right there. That's the substantive, is the organ. In organ systems, the noun is a system and the organ is an adjective, right? As opposed to a computer system or something like that. All right. Then system, so far, up at these 4 levels, these 4 basic levels, we're talking about similar functions, aggregates of similar function, right? Layers of similar functions to become more and more complex. Like, give me an example of a system, of an organ system. Any? Respiratory, circulatory, nervous, skeletal, muscular, and endocrine, epithelial system, the whole skin, all right? So there's about a dozen systems in the human body, depending on how you classify them. Sometimes the skeletal muscular system is classified together, sometimes apart, depending on who the specialist is. But my point here is that we jump to the next level of the organism. Now we have systems with different functions, with distinct functions, and that's precisely the whole point of the organism as a whole, all right? That the next level of organization or integration to the full organism then is systems with different function. Obviously, the circulatory system doesn't do what the respiratory system does, nor the neurological system, and so on and so forth, right? Nervous system. They have different functions. And that is the interesting and exciting thing about the organism as a whole. And that's how the organism really acquires integration and is able to live organically, is by having all those different systems work together. So if we lay out the dozen systems of the human body here, intact, each system, but they're not going to function right, we don't have a living human being, we have a dozen organ systems. They have to be integrated. And what is the system that integrates these other systems in the human body and in higher order animals? Which one is the system, the coordination or the integration system? Nervous system, the nervous system, which can be subdivided into 2 parts, central nervous system and peripheral nervous system, okay? According to whether it's voluntary or involuntary functions and so forth. But notice then that the organism, for multicellular organisms, the individual organism is analogous, if you will, to a single cell on the unicellular organisms, all right? And that's why within the cell, the structures that perform functions, distinct functions inside, are called organelles, all right? It's appealing to the sense of an organ having a specific function. All right, enough of that. Let's look at the vital organs of the body, because we realize that we have many organs in the body, and many are important, and we certainly want to preserve every organ of the body, but not every organ is a vital organ, right? For example, the eyes. Are the eyes, they're certainly organs, are they vital? Not in the sense that they're not keeping the person alive. You know, a blind person can certainly live. It's a major organ of our body because most of the information is coming through our eyes. It's estimated globally between 90 to 95% of our information comes through our eyes. And then the ear and so forth. But in itself, it's not a vital organ. And even the reproductive organs for the individual person, individual organism, they're not really vital, all right? They're vital for the next generation. So in that sense, as long as some people are procreating in the community, then that vitality is kept, but not on the individual level. So, and that's why reproductive organs may be sacrificed for saving the life of the person, you know, like in the case of cancers, typically. But there are some organs that are truly vital in the sense that if they fail, the person is dying, okay? And if that progresses, then the person will die. And that's what makes them vital. So This is a list beginning typically from the head down, all right, brain and brain stem. Okay, why brain stem? What's the brain stem? Yeah, pons and medulla, right? Medulla oblongata, here goes the Latin. And the brain or cerebrum, the two hemispheres and the corpus, uniting them and so forth, are essential mostly for what? Rational thinking, and it's part of the central nervous system, but it's also part of just the control, the voluntary control of the body, voluntary control of the body, including the thought process. But the stem is what controls the involuntary motion of the body, which is going to be typically associated with what kind of muscles? Yeah. So we got three types of muscles, right? Three groups. We got smooth, we got cardiac, and we got the, well, we can move around, skeletal, because it's associated with bones. All right, the smooth muscle is typically not attached to bone, and that is involuntary, and it's run by the medulla, like the respiration, the abdomen, the abdominal cavity of the respiration, which thanks be to God we have that, so we can breathe at night unconsciously. And the intestines, the stomach, all that peristalsis that occurs throughout the digestive tract, the GI tract. The heart is not technically a smooth muscle, it's a cardiac muscle, which is unique to itself, having its own rhythm, but also supplemented or complemented by the rhythmic of the medulla. So that's why we include the brain stem as a vital organ, okay? And that's going to be important, essential when we define brain death as one of the two accepted clinical death definitions. Heart, of course, lungs, both lungs, so you'll see both several times. Why? Why am I adjectivizing the lungs? Because one can live with one lung. In fact, it's actually 5 lungs, right? We got 3 lobes on one side and 2 lobes on the other, and the bare minimal is 2 lobes. So a person with 2 lobes can live. They're not going to run the mile. They're not going to be in the Olympics, but they can live a sedentary life, okay, and live. So truly, functionally, for vital organs, both lungs, the pancreas, which is single, both kidneys, the same argument. Whole blood, blood is classified as an organ because it's the only liquid organ in the body. But it does have, what are the tissues that are involved in the blood, for example? The two easiest one, the very easy one, why is it red? RBCs, right? That's a tissue because they're cells of similar function. And the other one, the WBCs, right? They're cells of a similar function, different from the RBC, so you get 2 different tissues there. Right? And then the third tissue, if you will, that it's also the cellular level, platelets for coagulation, and then the whole immune stuff, right? The killer cells, NTC, all the immune cells. That's a 4th tissue, if you will, and that's why blood as a whole is considered an organ. The only liquid organ in the body. Okay, the whole liver again, the argument because of the 3 lobes, and the liver has a lot of regenerative power. I've heard that maybe up to 40% of the liver can be sectioned, for example, in cancer and or the other one, cirrhosis, and will regenerate. It's a lot of regenerative power. The stomach, whole intestines, small and large intestine. We already know I talked about the difference between these two. You should know that the small intestine is longer, way longer than the other one, all right, about over 20 feet. But the diameter is smaller, and that's why it's kind of counterintuitive.
I have a question. Can you explain again why both lungs and both kidneys?
Well, because one can live without one lung and one can live without one kidney, all right? And therefore, to be vital organs functionally, both have to be deceased or both have to be infected, all right, or traumatized. Because if it's only one, let's say there's cancer on one kidney, well, that one kidney can be excised and the person continues living as long as the other one is okay. So I'm always thinking, you got structures, but try to make the leap functionally. And the whole skin, again, this has to do with burns, for example, over a certain percentage of burn in the body, which I don't know what it is, it's beyond recovery. All right, so burns are serious and important, including burns from steam, from boiling water. So be careful with olla de presión. If they explode, it's real bad news. Steam is very, very hot and can burn skin instantly. All right, so here's a list just for your consideration. The 15 most deadly conditions in the US by percentage of occurrence. This comes from CDC. And there's always a vital organ associated with it. Okay, so here's a list of the primary vital organ. I'm not going to read it all, but you can look at it later. I just want to focus on the first 5 that make up 2/3 of all deaths. Yes, 2/3 of all deaths in the US are these first 5. And within those first 5, you already have all the vital organs involved, whether the heart, the brain, the lungs, which are 3 major ones, but then any of the others with tumors, of course, cancer, and accidents in general. And then of those first 5, the first 2 actually take the big lead, make up 50% of deaths in the United States currently, okay? Heart attack and cancers. So it kind of shows our lifestyle. You go to other countries, especially countries that are called developing countries, all right? And you'll find that this list is very different. Probably accidents, I'm just guessing, but probably accidents would be more number 1 over there. But not so much as heart attack and tumors. In generally, they have a healthier life, and at least there's not so much stress. But the stress is taking a big toll on the heart, and also the immune system is. There's plenty of evidence that stress compromises the immune system, which then makes the person more susceptible to opportunistic infections. All right, moving forward then. So we're clear with these. Vital organs, about a dozen of them, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14 vital organs, again, depending on how we group them. But around a dozen vital organs in the body, okay? So that if the death process has begun in any of those vital organs, then the person actually is dying, and may be very subtle, but real. Yes, Jody.
Question. So for the prevalent cause, do we look at that slide or do we look at this slide right there?
This one, as opposed to this?
That's kind of different.
Well, with prevalent cause. Yeah, this one, right? And so this is all 15, which is in this 15 is 80% of all deaths, or more than 80, almost 85%, right? And all other illnesses, diseases, and conditions in the United States only amount to a little over 15% of all deaths. So that's the 15. But then within the 15, the first 5 is 2/3 of it, 75%, right? Or 67%. And the first 2 is 50%. So it's just, you can see an order of magnitude here from the 20s to the teens. So it's just highlighting our particular situation in the United States. because one way or another, this is going to determine the clinical practice, right? So did I answer the question? I'm not sure. Did I answer the question?
Yes.
Okay.
Thank you.
All right, so now we're going to move into the bioethical aspect of it. And again, there's going to be some discrepancy between the clinical terminology, the medical terminology, and the bioethical terminology. Because in bioethics, we use these key words, all right, these buzzwords, ordinary and extraordinary means of life support. So we're talking about end-of-life issues. A person has a condition that is serious, life-threatening. So the clinical treatment is going to be some kind of a protocol. Is that protocol ordinary or extraordinary means of sustaining life, right? Because what's going to happen is that ordinary means generally obligate morally, ethically, but extraordinary means don't obligate. They may be done if the person wants, or if the patient is unconscious, then the proxy or the next of kin, but extraordinary means do not obligate bioethically. And that's also why they're called disproportionate, and sometimes they're called heroic means. Okay, but so this is a critical distinction for making the bioethical analysis between an ordinary means of life support or an extraordinary means of life support. In fact, the ERDs mention that, they talk in those terms in part 5. Might as well bring it up, part 5. And if you don't mind bringing these with you to the next sessions, I'll be talking more about them. But part 5 and some of these parts. Oh, really? This one's missing 5? Oh, look at it. Oh, no, here it is. It's only 2 thin pages, page 25 to 28. All right, or 2 sheets, if you will. And it always has that same format, the introduction, which establishes some basic principles, and then specific directives. And you see this terminology, for example, on 56 and 57, which is referred to the ERDs by the number. 56, more obligation, ordinary or proportionate means. And then 57, may forego, there is no moral obligation for extraordinary or disproportionate means. Okay? So you see that that is a key distinction there. However, in the clinical practice, many times what you find is either a standard practice or an experimental treatment or protocol. All right, so a standard protocol or standard practice or experimental, and they don't necessarily match up. It would be nice if these two did match up 100%, you know, so that ordinary means are standard medical practice and extraordinary means would be experimental treatments. But unfortunately, they don't, because they're being looked at from 2 different perspectives, okay? And typically, standard medical practice or protocols is the state of the art currently, and that's going to vary also from country to country, from state to state, from hospital system to hospital system, etc. But you see, this is more driven by technology in the sense that it can be done. All right, it can be done. Whereas I'm talking about the clinical one, what is standard medical practice. However, when we go to the bioethical side of it, these ordinary means are defined more by what may or should be done, not necessarily by what can be done, okay? Excuse me. So the cold is also coming down this way.
I'm so sorry.
No, that's all right. It's not, you never know where you catch a cold from. It's all over the place. It's ubiquitous, right? Oh, yes, you do? Is that why she's absent today? Maybe. But yeah, these are the summertime colds because there's more temperature differential actually between inside and outside.
Yeah.
All right, so you see, they're driven by different factors. The clinical side is going to be driven more by what is a standard biotech possibility today, whereas the bioethical is going to look more at the person as a whole, all right? And is it a burden for this particular patient or not in their situation? So let's go a little further into this. And this is the distinction that has helped me over the years and decades of being in the bioethics field, to make the distinction between ordinary or extraordinary, and to try to find a link between the bioethical terminology and the clinical or medical terminology, okay? By looking at assisting or substituting vital organs. So it's kind of a two-step thing. The first step is identifying the vital organs. Is there one or more vital organs that are compromised, that are being affected, all right? And then, is the intervention assisting or substituting the vital organ? And that's the key link there, because I think that now when we talk about assisting versus substituting, both the bioethicists and the doctors, the clinicians, will understand a little better what we're talking about. So the key question is when to withhold or withdraw life-saving treatment, right? Life-saving meaning that it's acting directly or indirectly upon some vital organs, keeping those vital organs alive, because the vital organ is compromised somehow. All right, so let's go one step further and look at some examples. It always clarifies with examples. Before I go there, let me give you a general definition here, and then it will become clear with the examples. What is your intuition? Is there an obligation with regards to vital organs, okay? With regards to vital, is there a medical obligation to assist vital organs or not? If it can be done, you know, if we have the medical equipment to do it. Is there an obligation to assist vital organs? Yeah, because we're helping the organ, but the organ is basically doing the bulk of the work, all right? How about to substitute the vital organ? Do you think there's an ethical obligation there to substitute vital organs? No, all right? And when some people are not clear, because this can sound a little harsh at first, there is no moral obligation to substitute vital organs, okay? Or there is no ethical or bioethical obligation to substitute vital organs. Say, well, I have to think about that, okay? And as you think about it, when you're not clear about a proposition, you can turn it around on its head and see if the opposite makes sense. For example, imagine if there was an obligation to substitute vital organs. If there was a moral, ethical obligation to substitute vital organs. Is that tenable? Is that possible? You know, we'd have to substitute every failing heart, every failing lung, kidney, liver, you name it. We would have to. It's not possible. Clinically, medically, technologically, it's just not possible. Okay, so we cannot be held accountable for something that is impossible to do. And that's why really there's no obligation to substitute vital organs. But assisting, yes, if we have the wherewithal, equipment, and medication to assist vital organs, yes, because then that may heal the vital organ to get over the crisis and heal. Okay. So now let's look at some examples, and you'll see where the discrepancy is between the bioethical analysis and the clinical analysis. Let's take dialysis. What does dialysis do? Yeah, so it filters blood, right? Organically, what is it doing? The blood is filtered out, the blood is taken out of the patient's body, put through a machine, the dialysis machine, which is fairly large, as you can see here, and filtered, all right, literally, of its toxins, and then pumped back into the bloodstream, all right? And that takes several hours, depending on the mass of the patient, weight per volume, and so forth, and age, several factors are considered. And it's a regime that is fairly rigorous, all right, and taxing on the patient. Any of you know any dialysis patient, any person who's on dialysis? Maybe some family or friend? Yeah, it's, the typical regime is 3 times a week. For example, Monday, Wednesday, Friday for 2-3 hours, maybe 4 hours, depending. And then they spend the other days in between kind of recovering from the procedure because it's very draining, very taxing. Even though they're lying down all the time or sitting, whatever, it really makes them weak and drains them. So they spend Tuesday, Thursday, and Saturday recovering. Sunday typically is off. And then Monday they're back on the machine again. All right. So humanly speaking, it's a rigorous regime. There's some dialysis now that can be done overnight. It's a smaller, more portable unit and so forth. I hear that it's not as effective, but it has to be monitored closely. But it can be done overnight, sleeping at home. That's great. But still, that doesn't deny the fact that dialysis, whichever protocol is being used, is substituting the kidneys. It really does substitute the kidneys, okay? And yet, it's standard protocol, standard medical protocol for years, for decades. You tell any doctor, oh no, this is an extraordinary means of life support, they look at you kind of strange, strangely. And yet, truly, bioethically, it is an extraordinary means of life support. It can be, it may be extraordinary means, depending on each particular patient. It may be a patient who's been in it for decades. Most people are on dialysis. What are they waiting for? Yeah, end-stage renal disease, right? But they're waiting for a transplant. They're waiting for a kidney, either live or cadaveric, all right? And there may be years on the list. Right now it's about 90,000. Well, when I was doing the research a few years ago, it's about 90,000, and maybe 100,000 people now that are on the list on the kidney list for a transplant in the United States alone. All right, this has other implications at the international level with trafficking and all that, which is totally horrible situation, and that's why human organs should never be sold, bought and sold. It's altruistic donation, all right? And that's also why it's a good idea on your license to donate your organs, because what's the sense of taking them to the grave, right? When they can save the life of somebody else. But it's a culture. You talk about people donating their cadaveric organs, and I don't want to do that. Well, you're not going to feel a thing because you're a cadaver at that point. You could save someone else's life. But even living, if we have time, we can talk about living. Oh yeah, transplant. We'll have a session on transplants actually at the end, so we'll get back to that. But you see my point about substituting a viral organ. So it really doesn't obligate bioethically, and this patient can say one day, enough, I've had it. I'm going to go into end-stage renal disease and just die, okay, from intoxication. All right, so you see the challenges there. Let's look at another one. The ventilator, the vent, okay, the famous vent. Not to be confused with the respirator, because the respirator is assisting breathing, is assisting the lungs, but doesn't substitute, all right? So very important for you not to confuse the respirator with the ventilator, otherwise you're gonna be thrown out of medical school in your first day of class, okay? There are basically 3 types of respirators, generally speaking. They are assisting the breathing from the least assistance, if you will. It's just a little tube to the nostrils, and what's going through the tube? Oxygen, pure oxygen, okay? So it's enriching the breathing of this person, but this person is obviously breathing on her own. The next one is a nose-mouth mask that covers both the nose and the mouth, all right? But it's loose. It's loose, so that's the next level. And you'll see a little side back here, which I think is for collecting CO2, but that side back typically is collapsed, and people freak out and say, well, why is the back collapsed? Oh, it's supposed to be like that, collapsed, okay? But then the third one is the most aggressive assistance, if you will, which is a mask that is actually strapped on to the face around the face of the person, including mouth and nose, so that it is providing 100% oxygen to this person, all right? But it's still assisting because the lungs still have to do the work of intake and output. This is the most aggressive one, and it has also psychological implications because the person can feel asphyxiating with this more so than with these other two. All right, it's kind of psychologically equivalent to putting a plastic bag over your mouth and nose at the same time. So the person has to get used to it, and sometimes they're unconscious. But this is the respirator, all right? It's kind of counterintuitive because the ventilator, you think that the ventilator is assisting. No, but the ventilator is a tube that goes into the lungs, right into the lungs. So it's a much more involved machine that regulates the breathing of the patient and can actually take over the breathing of the patient by the pressure of that air going into the lungs. And the typical thing that is measured is called perfusion, which is the percentage of oxygen in the bloodstream. And it can be measured with, a little thing that is put on the finger like this. It's a little device. And that measures, I think it's actually measuring the electrolytes that are coming through the sweat or something like that. It's a very sophisticated little cap. All right, and with that little cap, which is totally non-invasive, they measure the perfusion rate. Anything below 98 or 97 or 95% already, they start getting leery and they up the percentage air. Okay, because we should ideally have like 98 to 100% perfusion. It's absorption of the oxygen. The basic protocol is that they start weaning right away. As far as I know, nowadays, as soon as a person is put on a ventilator, and originally the tube goes through the mouth, the person is sedated, and the tube is inserted into the lungs, all right, down the trachea. As soon as the person is hooked onto the vent, the settings are set to what the patient needs. Originally, let's say they start with 100% vent, meaning that the vent is doing 100% of the work. All right, the lungs are passive at that point. They start right away to wean. In other words, they start lowering the percentage of air that the machine is pumping into the lungs on an average of whatever it is, 18 breaths per minute or more or less around there, okay? And see how the patient reacts, how the lungs react. If the lungs are beginning to take up some of the work, that's a constant process, the weaning process, and it's a very dynamic system. So this is being monitored really at every step. You can see the screen has all the vitals going on, and they're measuring the amount of CO2 in the blood and the amount of oxygen and so forth to see how much of the lungs are reacting. The typical case, for example, could be a pneumonia. So they need to rest the person and attack the infection, and then what's going to be administered to the patient with the pneumonia. Typically, antibiotics intravenously, right? Antibiotics intravenously, and so once the antibiotics are doing their thing, then the lungs are restoring and are gaining back function, and so in a positive prognosis. Oh, here's the little cap that I was talking about, right in front of my face. This was measuring the perfusion of the patient. Okay, which you can see is connected to the monitor. At any rate, if the patient is reacting well, then the settings will be lowered and lowered and lower until they get to about, I don't know, I think maybe anywhere from 70 to 50%, more or less, Then the protocol calls for extubation. And the ideal is that the patient lungs will take over. And in that next breath, once the patient is extubated, in the next breath, the patient's lungs will do 100%, just like a newborn baby, right, with the first breath. So, and that's the standard protocol when things go well, when the prognosis is good. More than 2 or 3 weeks on the vent, then the throat is too irritated, and they have to do typically a tracheotomy to reinsert. They have to extubate and reinsert the tube through the trachea, bypassing the throat. All right, and that's called a tracheotomy. The hole itself is a tracheostomy. Stoma is a reference to hole or opening, or also os, like the mouth, for example. All right, and some people can live with a tracheotomy or tracheostomy later on, once they recover from the illness, either with a scarf or bandana or something. Sometimes you see just a little pad on the throat, all right, on the lower part of the neck. This is a little filter to prevent, because you want to prevent particles from going in there. Of course, they're going to go right into the lungs, all right? And there's a little device. But my point here is that after 2 or 3 weeks, maximum, then the doctors and the patients and the people involved have to make a decision whether to re-intubate through a tracheotomy if the prognosis is poor. Once the patient goes into a tracheotomy, then that vent can be maintained essentially indefinitely, and the person could slip into PVS, persistent vegetative state, for example, and stay for years on an event like that, you know, which is a very challenging thing, because what is the quality of the life of that person, right? And yet the machine itself, so event is either assisting or substituting. What's your intuition? Bioethically. It can assist or it can substitute, right? For example, at the very beginning, if the patient is hooked up to the vent, protocol starts at 100%. So there is substituting, okay? But then if the prognosis is good and the medication kicks in and so forth.
So it's only substituting if they're not working 100%.
Correct. Or, you know, if the vent is doing anything above, if you want to put a percentage precisely, I guess that could match the protocol, the extubation protocol, anywhere from 50 to 70%, then the vent is still substituting, all right? But this is one particular case when there is a substitution, but it's a temporary substitution. And so at some point, again, I re-emphasize, it all depends on the prognosis. Remember, the diagnosis is the current state of the patient. The prognosis is the hope of recovery. If the prognosis is good, then a temporary substitution may be accepted and may be considered obligatory because the prognosis is good, you know, or excellent. And you can load the basis if you want bioethically. Well, this happens to be a young person and he's the only one who is working and maintaining the family. So it's important that this person get back to life, an active life, because he's maintaining the rest of the family and so on and so forth. Okay. But my point is that sometimes you have with the vent a temporary substitution of the lungs, but the big picture in the overall scenario is that there will be, it's a good hope for recovery, so eventually it will become assisting and then extubation, and the patient will most likely heal, right? Then one could make a case for, yes, we should intubate this patient because it has a good chance of recovery. So this is a case where the vent can assist or substitute depending on several factors, the background health of the patient to begin with, including their age, the type of disease or illness or trauma that they're sustaining, their overall good health or stamina of the body, you know, if they're a healthy body and so forth. So many factors go into determining whether the vent is assisting or substituting, but my point is that it can go either way here, all right? And therefore, what do? You go patient by patient. You go patient by patient. Another example, we can focus on the heart now, CPR. CPR, what does CPR do? Cardiopulmonary resuscitation, right? Resuscitation, it is actually, CPR seeks to restart the heart. So the heart has stopped. A vital organ has stopped functioning. And if that heart doesn't start spontaneously on its own, that heart is dead or very actively dying, okay? So CPR could be substituting the heart or could be assisting. Again, a lot depends on the subject, on the patient, and typically the age is a big factor here and the overall health. So age correlates with positively with health, right, in general, in the general population, so that younger people are healthier than older people in general. Mm-hmm. For the old, what's the big issue here with CPR and the compressions? Collapsed lung and breaking ribs and punctured lung. All right, so for an elderly person who goes into cardiac arrest and
like a infant too.
And also, exactly, so thank you, the very old and the very young too. Mm-hmm. So in fact, I think, I'm not clear on how it is, but the protocol for compressions on a baby is very different, right?
You use like
just 2 fingers?
Yeah,
interesting.
2 or 3 depending on the size.
I see, look at that, very good, okay. Learn this, learn CPR, it's free training all over the place and it's worthwhile, all right? You could say it's the life of a person. Mm-hmm. And also the Heimlich, while you're at it, learn that Heimlich procedure. That saved my life one time. On me, I had to ask another person, get behind me. And no, I just grabbed them and push, and get the piece of meat out of my mouth. I was choking. Couldn't believe it, but it's all within 1 minute. So that has to do with the residual air that we have in the lungs that is always left there after we exhale. It's a very important amount of air. Okay, so CPR could also either assist or substitute depending on the patient. We have to go patient by patient, but particularly the very young and the very old, it gets more critical, all right? So when in doubt, you always want to consult an expert. Hopefully there'll be some professional nearby that you can consult. Also defibrillators, like the one we have here in the hallway, it doesn't really restart the heart. That EAD, all right, electrical assisted defibrillator, assistive, doesn't restart the heart. It actually, when there's an arrhythmia, what it does is it tries to synchronize the heart. It stops the arrhythmia and hopefully the rhythm, the natural rhythmic synchrony of the heart will start up by its own, all right? Through the nodes, the AV node, and in coordination with the nerves of the brain stem. So the defibrillator really assists the heart, all right? It doesn't really restart it. And I was reading that sometimes here popular culture and movies and so forth, films don't help, because when they come, the emergency team rubs the thing and hits the patient and the patient jumps, and oh, that is very dramatized. And it's not really that dramatic, okay? Because it's a current that actually defibrillates the heart and then the heart starts up again, but it doesn't make the whole trunk arch or anything like that. Okay, so generally then the defibrillator assists, and then that's a good thing why we should learn how that machine works on the hallway there. So we can basically come to the conclusion here at the bioethical level. Is the particular protocol to be implemented assisting or substituting the vital organs? Okay, whatever vital organ. Well, if it is assisting, yes, there is generally an ethical obligation, but if it's substituting, there is no obligation here. Okay, it may be done, like I said, but doesn't have to be done. And so we can ask a question to the doctor from the lay perspective, and here trying to help relatives and friends, especially if the patient, either the patient is conscious or if the patient is unconscious, to help the next of kin or the proxy who is going to make the decision, how to dialogue with the doctor and ask the proper question. Are vital organs involved in this particular illness? Yes, no, which ones, and are they failing irreversibly? If vital organs are failing irreversibly, then the death process has indeed begun. It may be subtle or it may be dramatic, all right? But many times it's subtle but real, and it's irreversible. And so if the vital organs are failing irreversibly, the patient has begun to die. And then it's a question, are we extending life or are we actually extending death? And that's where I'm going to pick up next class when we talk about physician-assisted suicide and euthanasia and all that. Are we extending life, extending death? What's going on there? But this one sets up the basic principles to be used here. Again, recapping in the beginning, the distinction between ordinary and extraordinary means at the bioethical level, so we can make a value judgment, and trying to bridge that with the clinical language of standard practice or experimental treatments. And in my opinion, what can bridge this is to talk about assisting or substituting vital organs.
So would that fall, the assisting or substituting, which one would that fall under?
Well, exactly. So if I say that, what is your intuition? Is assisting vital organ obligatory or not?
So that would be standard medical practice, no?
Not necessarily. It would be ordinary means. It would be ordinary means of life support, okay? It could be standard or it could be experimental. It's more in the other direction, all right? In other words,
I don't understand the standard medical and experimental treatment.
Okay, because this is at a clinical setting. For example, the first example that I gave is dialysis, right? Mm-hmm. Dialysis is it assisting or substituting the lungs? The kidneys.
Yeah.
Substituting.
Mm-hmm.
All right, so substituting vital organs. Therefore, dialysis as a whole is an ordinary or extraordinary means of life support. Mm-hmm. It's extraordinary means of life support. It doesn't really obligate. A patient could walk away from dialysis in good conscience. All right, but for the medical practice, in the medical practice, dialysis, is that an experimental treatment? No, it's been going on for decades. It's a standard medical practice.
Oh, okay.
It's a standard medical, so they don't always match up. That's what I'm saying. They don't always match up. And that's why I'm introducing this link in between, this bridge of assisting or substituting, because a doctor will understand. You can ask a doctor, is this dialysis machine assisting or substituting the kidneys of my relative here? Hopefully the doctor is honest, it's a person of professional integrity, and say, well, it's substituting the kidneys. In fact, you know that when people go on dialysis, they actually have to sign a consent form, because it fools around with their osmotic level. It's an osmoregulator. The water in the blood, because the water is used to dilute ammonia and the toxins in order to urinate them out, right? That's why the urine is yellow, because it has the nitrogen byproducts of breaking down protein. So the machine, the dialysis machine, is an osmoregulator, and the kidneys, in addition to filtering toxins, simultaneously they osmoregulate, right? They establish the amount of water in the blood, and by doing that, they establish the blood pressure also in coordination with the arterial pumping. Okay, so bottom line is that the dialysis machine could send the patient, if there's a malfunction, they could send the patient into hypertension and cardiac arrest. All right, because it's playing with its amount, with the amount of water in the that has to be taken out, and then the machine has to pump in water to substitute the water that's been taken out.
And the dialysis doesn't go so, I mean, it would be a treatment that would work for only a few years, but after a certain time, like it doesn't cure.
Right. It doesn't cure the patient because end-stage renal, or not, the kidneys are shutting down irreversibly, so it doesn't really cure the patient, but it can extend the life of the patient. And the key question is at what point does it extend the life or extend the death of the patient? Because the kidneys are indeed dead or dying,
Okay, so question. What about with chemo and cancer? Would that be considered? I know technically it is a standard medical practice because they've been using it for a while, but can it also fall as an experimental treatment? Because, it's like you're taking that chance on varying between patients.
Yes. So the answer is yes to both.
What would be an example of an experimental treatment?
Right. Yes. Notice how I put here cancers, all right? Even though generally we see cancer in the singular, but let's say that the only cancer that's in the singular is metastatic cancer as a whole, that's all over the body. But we have bone cancer, we have liver cancer, it depends on the organ, all right, brain cancer. And so it really depends where the cancer is and what kind of treatment. There are some cancers like skin cancer. Some kinds of skin cancer is very easy. You just excise it or you leave it alone like mole or so forth. But other cancer is very aggressive and there is essentially no cure for it. There may be some experimental treatments, all right, like the glioblastomas and the brain cancers. So those are experimental treatments which typically have a chemo and radiotherapy or both or either one, but those are experimental treatments. Now some are standard medical practice, all right, but and some people do cure from cancer, all right. I mean, one that is fairly simple to cure, if you will, in itself is cancer of the reproductive organs. They come out, all right? And so, but then typically there will be a round of chemo or not, maybe depending on how soon they caught that cancer. Right? So you see many factors really, but the whole point here is simply to state that what may be considered standard medical practice is not necessarily ordinary. It could be extraordinary. It really depends patient by patient, the condition of this particular patient. All right? Sure. I'll tell you more. Even, let's go back to 56 and 57 for a moment, since I have a couple minutes. You'll see how much latitude there is here for extraordinary means, how subjective this can become. All right? In 56, which I read the part, the beginning, a person has a moral obligation to use ordinary means, all right? But look at the end. Those are reasonable hope of benefit, so that's the prognosis, and do not entail an excessive burden or impose excessive expense on the family or community. Okay, so that, what is an excessive burden for one family with lots of means or another family with little or no means? That will make a difference. On the extraordinary, it's even more poignant, if you will, more graphic. When you look at 57, a person may forego extraordinary means of preserving life. Disproportionate means are those that in the patient's judgment, do not offer reasonable hope or benefit or entail an excessive burden, you see. So this gets into the psychological. This patient who has been on dialysis for 40 years has just had it and doesn't want to do this anymore for half of his life, being on and off, one day on, one day off. That can be an excessive burden. It doesn't say physiological, it can also be psychological. And that patient in good conscience can walk away and say, I've had it. I've been on the list for 40 years. I don't qualify. I'm a low candidate on the transplant list, and therefore it's time for me to go. Okay, and so it just became a standard medical practice, became extraordinary, bioethically speaking. Sometimes some doctors have difficulty with this, and it's important to bridge the gap. Of course, with time, with time, that's another way of looking at it, perhaps, finish with this. With time, what's the expectation that experimental treatments, where if we drew arrows from standard practice into experimental, or from experimental to standard practice, with time, which arrow do you think is valid? Exactly. For experimental to standard. Even transplants themselves used to be experimental treatment. Most transplant patients did not survive when it started. It's totally experimental. Now it's becoming more and more standard, okay? And so there's a one-way passage here, generally, with time. Whereas these, it depends. They can stay as they are. You know, it depends really patient to patient between ordinary and extraordinary, because it takes the patient as a whole. And if the patient is unconscious, then whoever is deciding on behalf of that patient. Okay. Excuse me. Any questions, comments? No? All right, so I'm going to stop this then. Thanks a lot. And we'll see you again on Friday. And in the meantime, please read that little article that I sent you. It will help you, I hope, do this particular summary. All right. And so for your benefit, and also remember to bring the ERDs from now on. Okay. Thanks a lot. Okay. You're welcome.